Here,
I'm sorry. Oh, Mary, sorry.
Hi. So at the end of the day, healthcare is delivered by people, not technology. And when I moved from the inpatient or more acute care focused world to the ambulatory world that I live in today, when I watch constantly physicians, nurses, MAs struggle with workflow. And I haven't seen a lot of great technology changes to help that workflow. And the number one thing I hear from clinicians, and Harris, you know this, is give me time back. That's how you improve quality of care. So most of the regulatory and other things that have been happening are just adding layers and layers of time to their day. What do you see or hope to see, or if you had to put your money on one type of technology to really help the workflow of the clinician of the future, what would you change? What would you like to see? Because I really see that as being just continuing to get worse.
So I'll take a shot and then pass it.
Mm-hmm.
So your observation, I think, is probably shared by everybody in this room, and especially the frontline clinicians, is, you know, we constantly hear how we're taking away time from the patients. And, you know, in the continuum, you know, some of us like to measure, well, if you take the whole day, maybe you're not losing as much. You know, that argument goes about nowhere. But I think the hope is that the presentation layers, there's an awful lot of really smart companies, some of them very big, well-established, are working on that presentation layer. And the presentation layer is taking all the data, reformatted in a way that has become an actionable based on whomever they're going to see, and organizing it in a streamlined fashion, stripping off a lot of the interesting but not important, and making their workflows can in fact be improved in that. And I'm seeing some of that. That to me is highly encourageable. I think that's going to make a difference.
I think it depends on the discipline area. So like in the ER, we were able to take the physician's productivity. The first month, of course, it was decreased. The second month, it was neutral. And by the third month, they had gained productivity. By taking all of their workflow and automating all of their workflow through voice recognition all the way through the end. I think we're just in the early stages of the workflow changing from the inpatient point of view, but you know, the clinicians are looking for a nice, easy way to pass the communication on, and I think that we have to look for communication aspects like the device that they're using all the time, to be able to send information about their patients or orders, whatever, in the form factor that they're using. So I think that can improve the workflow if we can find those mechanisms to get them implemented. You know, because what I find, and I don't know if everybody else finds, but I find physicians, you know, they're admitting the patients and they're not actually coming in to see the patient, to admit the patient. They're just taking, and what I'm finding now is they're pulling up the information about the patient at home and they're reviewing it, and then they're giving their orders right then. And hopefully they'll be entering them. But you know, when they're in their car or they're, you know, at the mall, or we've got to find better ways for them to communicate easily based on the form factor that they're using.
I certainly agree with the comments that have already been made. I think there are technology solutions that can assist. Voice recognition, using mobility solutions and form factors to best advantage increasingly intelligent systems, so that documentation of one thing that presupposes several other things are also occurring can happen without the need for additional clicks or additional activity on the part of the clinician. Those are all important, and hopefully we'll see those all come to fruition. We're certainly working on many of those, and I'm sure that everyone else in the room and next to me are also working on those technology solutions. But again, as I indicated earlier, you know, I think a lot of this really has to do with the way that we've kind of gotten organized, that the workflows and the documentation that we're doing now in many cases is replicates what we were doing before on paper or sort of semi-automated solutions, and we really need to get beyond that. We really need to sort of figure out, how does every person practice at the top of their license? How does every person do only what they need to do and document only what they need to document within the system, so that the next person obviously knows what's going on and the handoffs can be handled seamlessly. And everybody still get paid appropriately based upon what they're doing. You know, the way it's structured now too often is we have too many people doing too many things, and I hear this from the physicians all the time, is that this is taking me too much time because they're clicking all the boxes so they can or someone in the billing office can mark this off as an extended visit instead of an intermediate visit or a brief visit. You know, there have to be ways for us to be able to make this process a lot more efficient while still allowing folks to generate whatever income is appropriate given the services that they provide.
I was at a vendor conference recently, and they showed a slide that demonstrated the trend that as patients are using more and more of the EMRs, it's possible patient logins to the EMR may actually eclipse provider logins. And so I guess my question to you all is, do you think we're ready for that trend? And if we are not ready, what do we need to do to get ready?
Would that be via the patient portal, or you're actually seeing directly into system A or B?
In this particular presentation, it was the portal, but I think there's
Okay.
going to be lots of different interactions coming up.
Interesting. What do you think?
I don't know that I see them directly adding information into the EMR. I see them accessing information. I think what I do see is I see somewhat of a community portal where not only patients but families, physicians can all access and communicate together so that people are aware of what is transpiring. So if I'm a caregiver for my mother, I can look in, I know what she's scheduled for, I know what her meds are supposed to be, I know that she's documenting what she should be documenting, and then an avenue of communication to the physician. I see that coming, but and I'm probably wrong by saying that I don't see it going directly into the hospital EMR, but right at the moment, I don't see it going into the hospital EMR.
It's a great question, and it's certainly something that we're looking at and working on quite a bit these days, as I'm sure most of you are as well. I think in this one particular case, the technology, I think, unlike most of the other things we've been talking about, has kind of outstripped, you know, our organizational or logistic or maybe even philosophical approaches to how we're really going to manage that very patient-centric approach. So I think that, you know, patient portals are something that we all have, or certainly we're all working on. Patients' ability to communicate through secure messaging and other forms has really developed quite quickly, and something that we're, you know, broadly supportive of. I guess we probably have over 100,000 of the patients within our network who are currently accessing their information on the portal, and I don't know what percentage are actually sending secure messages right now, but it's a reasonable number. But insofar as we're using that for a well-defined, well-thought-through, well-organized patient engagement approach, so, you know, pushing out all the right information to them, being sure to make sure that we respond appropriately to the questions and comments and corrections that they have in their electronic health record, that we still have a really long ways to go on that. You know, who's doing it and how does that all work? We're working on it, but I think in this case the technology has gone a little bit faster than we were prepared to deal with it.
So you didn't really, I didn't hear the question this way, Darren, but I would say that I don't think we would ever do a service to our communities by allowing direct access. And if you think about that, if you just look about the records today and what's in there, quite honestly, you know, I'm a nurse, and there's things in there that I'm not sure of, and I have to go refresh myself. However, with that said, I do believe fundamentally that record belongs to the patient, the end. 100% belongs to the patient, the end. And so it's our job through our portals to be the translation agent on that and provide them the information in a way that they can understand it, that it is meaningful, that it is secure. And I think, if you talk to the people in this room, we'd have some that are really incredible portals that are out there today, and they're I'm in awe of them, to others that, more closer to where we're at, we're in the infancy of that. But at the end of the day, it is the patient's record, and I think we owe that to them.
It's a question I would open up for even the audience and folks that have an opinion, but also the panelists. This idea of sort of customer relationship management that I don't think we do a great job at. I've been a patient in my facility multiple times, as many years as I've been there, and it seems more often than not, and I don't think it's unique to my experience, but with family members, friends of family at other organizations, unlike the airlines, the banks, and others, hotels that seem to always remember, if you go to the same one, who you are and your preferences and the like. We're always a stranger. And I think it goes beyond enterprise, patient master index, all of the rest of it. It's a little bit patient portal. It's a little bit engagement, I suppose. But I'm wondering if you have a specific strategy, if it could be labeled customer relationship management, and at some point, are you thinking about the fact that the patient experience, when the high deductibles and everything else really matter, that patients may choose based on their experience? Yes, they presumably choose on quality and everything else, but they tend to think that all clinicians, all hospitals are generally okay. But to the extent that that may or may not be true, the customer experience may matter, may dominate the situation today. So what are people doing? What are you doing? What do you have in mind for CRM that we find in almost every other industry? Anybody? Any opinions anywhere? Ideas, thoughts, suggestions? I'd like to know. Back here.
I just have a follow-on to the communications issue, and that is the question as to whether or not the education process, because learning a software is so complex, is really taken seriously, especially by hospital administrators and doctors. It's very easy to, say the software is, or rather a server costs X amount of dollars and so on and so forth. It may be harder to quantify the education issue, but I'm just wondering if you guys have any input about that.
We got two questions in front of everybody, so thoughts? There's an opinion over here. Mr. Nafis.
Yes, prior to getting into healthcare informatics, I was in pure IT, developing CRM. And I always thought that the reason that CRM had a presence in all other industries is because there was a strong financial incentive for it long ago. And that healthcare has been the only industry that really had no financial incentive until very recently. So there wasn't any incentive to get into healthcare, but there was to get into all the other industries that I worked on. And to this date, I'm still waiting to see the big players in CRM getting into healthcare, and they as a real CRM application rather than just building upon what we've already had here. So that's just. I think that there just needs to be more time given with this financial incentive, and then I think the big players will start getting into it, and you'll see a lot of solutions for it.
Yeah. Here?
You're looking good, Steve. You're looking good.
Get a little exercise there. All right.
Working off a couple pounds.
Microphone.
So we're doing something similar in the CRM space, and I think a lot of people are, but using some tools to identify gaps in care because we're managing the patient. We're a multi-specialty medical group, different than hospitals, and of course that's a lot of that conversation is who's really, managing that, who should be managing that customer relation to what level. So, but it's interesting, some of the data disconnects that occur, that we can do everything from just make sure when you're in the office that somebody's reviewing, your information is right there. We have a dashboard, gaps in care, what you should be getting, what tests you should be getting, to outreach calls, outreach emails, going to your portal and seeing, hey, I'm due for this. Well, we've had missteps. Now, when you get an ad in your email that says, hey, should you buy this? Should you, based on your preferences, nobody really gets that mad. You delete it. If you tell a patient you're due for this because of this condition, they're like, I don't have that condition. Why are you telling me I have that condition? Because of some of the way that data is aggregated. So you can have some missteps in the CRM world with healthcare data because you're trying to give them an experience. I mean, I know you were probably more talking about customer relations experience or just, customer service, but at the end of the day, trying to give them a personalized experience in terms of their healthcare, actual healthcare services, not just customer services. It's challenging because of some of the data missteps that we've had.
Other questions here?
Just one thing, a comment on having patients have access. There was a project called Open Notes, and that was where they opened the notes up to the patients, all full notes, and after the project was greater than 95% of the patients wanted to continue, and I'm going to get this pretty close, about 50% of providers thought it was very valuable, but there really was not a lot of negative effects. So if you Google Open Notes, there's a whole bunch about that. And my second question is, nowadays, if you had a choice between two integrated delivery systems or providers, would you go to one that didn't have a patient portal?
To me, that's a non-question.
Yeah.
I don't think that's an option. I think if anything, one of the collateral benefits of meaningful use is they've decided that for us in many ways. Now, maybe a question that I would add to yours is, would I go to one that meets the minimum requirements, or would I go to one that had differentiating services? And like anything else I do, if the cost is about the same, the quality is about the same, I would go with the differentiating services.
I agree.
Yeah, I mean, I think that's absolutely right. The idea that the information that we're collecting in the patient's electronic record, or non-electronic record, if that still exists anywhere, isn't the patient's, I think is an idea that has come and gone. I think we're all kind of on the same page that the information that's in the patient record is the patient's, and anything we can do to make that as transparent as possible is something that we really need to do. I'm sort of leveraging on Scott's comments about customer relationship management, and certainly something that we're looking at. It is a big leap, I think, for many of us. We certainly at MemorialCare, we started out as a couple of hospitals, and then more hospitals, but still mainly managing episodic care, and customer relationship management really wasn't something that really concerned us. I mean, we had and still have a contracting office, and they, go out and negotiate contracts so that patients who are going to get admitted to a hospital come to us because that's part of the plan that they're on. Now, as we become an integrated delivery system, as many of you have as well, and we're managing the continuum, it's a very different situation. So it's not so much that the patient is just sort of coming once and then we might not see them again for 10 years. They're really part and parcel of our organization. And as Scott has said often at meetings back at the office, we just can't let patients come in to our hospitals or our physician's office and be treated as if they're a stranger. That doesn't have to happen very often before they start thinking, maybe a different plan or a different, or I'd like to do business with a different organization is going to pop into their minds.
I think that's a good part of your question. I think as a patient, chances are not everything is the same. There are some minor differences among those two providers. I think the question really is, to what extent does that portal in the patient's mind dominate what may be some other advantages? And you're going to presume, I think, a certain amount of quality being, as Tim said, generally speaking, if they're equal. So what is going to be the driver of the decision? There may be one may be a little farther away. But thinking about all of us and all the things we have going on and about our lives and the way we do banking and everything else today, I'm looking to save time and convenience. So there's a presumption that this organization may be farther along in their thinking, and they're more concerned about me. But generally, I'm looking to save time. I want to be able to get a prescription refill or otherwise correspond with my physician So I think I would strongly prefer all other things being generally equal. That's going to tend to dominate increasingly my choice for somebody who's going to be with it, so to speak, and have a portal of some kind so I can interact with that clinician. And I think those who don't go there increasingly over time will be severely disadvantaged, if not out of business. Back in the back.
Richard Katz again. Let me switch gears for just a second before we end for the day. As most of us know, under the HITECH Act, there was about $100 million spent to educate approximately 20,000 people in the colleges to help give them the skills that they needed to enter into the health IT area. And most of those students didn't really find jobs. So my question to the panel is, can you guys sort of help predict in the future or even now, what skill sets would you say would be most in demand in the health IT field so that people here and others can guide their education and work experience? Anyone?
Well, for me, I think it is on the informatics side, the clinical expertise. It's understanding the systems as well as understanding the workflow and the operations from the clinician standpoint. I think, even I have 3 physician champions. One is 85 years old, and the other 2 are under 40, and the other 2 are seeking out their informatics degree as well. And I just think that's the expertise that's going to be needed from the HIT side.
I would certainly agree in principle. We have a group within our organization. We call them clinical training specialists. That's really a misnomer, but they're the concierge staff, and we've hired actually some folks that have come out of those training programs for this program. I don't know, we probably have about 30 of these folks within our organization who are really the bridge between our physicians and our nurses, both on the inpatient and on the ambulatory side, to sort of translate some of the gobbledygook that I send out there, I suspect, and really help our clinicians understand how the systems work, help them deploy the workflows that they need to make the technology that we're delivering work for them. I think that's really going to be the major niche within the healthcare organizations that most of us represent. I don't think we're going to really see an increased need for the hard software developers within our organizations anytime soon. Those folks obviously have some opportunities on the vendor side, but we're not doing a whole lot of self-programming or reprogramming, if you will, of the vendor software as we get it. We're working on configuring it appropriately, figuring out how to bake it into our workflows, and then educating our clinicians on how to use the software most efficiently and effectively. And those sorts of folks, our concierge community really has a major role to play, and I can only see that group getting, over the last 5 years, it has just gotten bigger and bigger and bigger. We started with a half dozen, and then a dozen, and then 2 dozen, and now we're well above that.
When you asked the question, I thought to myself, I wondered if the timing would have given a different answer. So when those investments were being made, the reason for those investments, right? That was an infusion into our economy in many ways, and it's tough. I've in my organization, the IT organization, although one of the most valuable resources, but on the pay scale, the person that is paid probably the least are our administrative support folks. And then the last several years, in fact, the 4 years I've been associated with Hoag, I've been able to fill each and every one of those roles with somebody that has at least a bachelor's degree. And they're taking very, very little pay. And so we're able to go out and get those resources, and we use that as our entry points in each and every case. And those people have excelled extraordinarily well. So I think maybe part of it is just the timing. But the second thing I would say associated with that is, and I think it was what you said, Cindy, is I absolutely believe informatics, and understand hospital and subacute workflows. If you really understand that, you're invaluable.
Yeah, I would add to that. I think there's two parts to it. There is the innate skills of the person, and one thing I find sometimes lacking, especially maybe the younger generation, or maybe it's just my perception of how they approach life in general, but just an innate curiosity, an interest and willingness to sort of pursue things at several levels of depth, to really think about things, because so much of the analysis and so on to understand the workflows that Cindy was talking about comes down to an innate curiosity to figure out how things work. Great communication skills, and I think some of these things can be learned, and some of these things are just, an innate skill. But otherwise, business knowledge, I think, as Cindy was alluding to, is really important, especially with clinical knowledge, but just the knowledge of healthcare and informatics in general. Project management, or at least some concepts of how to put things in order, that in fact there's a logical way to approach getting things done. I think those things really matter on a go-forward basis. Maybe one more here, and we'll call it a day.
The things I see from a CRM standpoint is, I think, first of all, the tools that exist today are not necessarily directed toward the healthcare environment. What I mean by that is that we have both, I think, weaknesses and opportunities in both the areas. For example, when you look at CRM tools, they really decrease patient engagement, okay? Automated calls, emails out to the patient, that type of thing. So that doesn't really increase patient engagement. The second thing is that we do have an opportunity as far as using patient surveys, satisfaction surveys, physician satisfaction surveys, which we could actually use CRM tools to do. And then also, really where the CRM activity is being driven is from the payer companies, which are actually doing post-discharge care management services, where there is some form of personal interaction from a CRM standpoint with the patient at the time of discharge. I think we have a true opportunity with accountable care organizations to increase that patient engagement. But from a provider standpoint, it just is not catching on for some odd reason.
So I think we have a raffle, but I would like to thank everybody again for hanging around. From my point of view, as daunting as this work is, we're watching the transformation of an industry going from paper to paperless. You're actually watching it happen, before your very eyes. I think we're really lucky. I feel very fortunate to be in healthcare and be in healthcare IT, because we have a chance to really apply technology. Sometimes it works, sometimes it doesn't work. We're learning as we go, but we're making it happen right now, and it's going to be at least a decade, I suppose. But it's really cool stuff. I think programs like this are the way that we can share learning and get things done and figure it out and maybe go a little bit faster. So thank you very much.
Thanks, everybody, for sitting in your seats, and panel, thank you for a great job. Scott, thanks for being the moderator. So we have a couple of raffles here for from the chapter, and then a couple from Nudesic. So we're going to do the Nudesic ones first. Mary Kay, why don't you pick a